Call the meeting to order at 5 o'clock. Roll call, please. No problem. When you're ready, just call roll call.
Yeah. Greg Alexander. Here. Mike Baber. Chris Brune. Here. Adam Carson. Lindsay Keisman. Here. Ray Lapinus. Amy Rath. Here. Kara Schofield. Here. Connie Machini.
Here. Just to let you know, Adam has let me know he may be coming a little late. Public comment. I don't have the sheet. Is there any public comment? If not, we will go in. Oh, do you have public comment? Okay, thank you. We will go into presentations. Presentations should be 5 to 10 minutes, and it will be timed, and then 5 minutes for questions and answers, okay, so that we keep it concise and going. The first one is Best Communities. I believe it's Lori Crane. Just make sure you press the button that's green, Lori, so they hear you.
There we go. Okay, thank you for a chance to talk a little bit about the Peer Support Center that I submitted. I will go as fast as I can. So the goal of this is to primarily support and target into what I think is a gap in our area and build volunteers, recovery coaches, certified peer support specialists, and the CADC role. This is a group of people that if we can build them, I think we can decrease some costs, and I'll go into that a little bit more. Volunteers, if we can build them up, I think offering some different types of training that are kind of at a lower level of contact. So for example, if we think about, we throw out a lot of times motivational interviewing, and if I compare this to a college level class of a 101 math that we all kind of are required to take, sometimes people are asked to take that 97 level class, and sometimes we need to ask people if they need that 97 class of a motivational interviewing, because we assume sometimes everybody knows what that is, and sometimes we need to offer a little bit more basic level to get people warmed up to it. And our volunteers sometimes are those people. The same with our recovery coaches. So recovery coaches, to clarify what they are, recovery coaches are usually individuals who have certification. They are not people who are certified. So I'll clarify certified peer support specialists in a moment. Recovery coaches in McHenry County are people who are usually trained in the CCAR, which is the Connecticut certified, the Connecticut Community Addiction Recovery Community. We have 4 trainers who were trained at one time. Myself, Brenda Napos, Michelle Kavoris, who's in Alaska, but who does do virtual training with us, and Dan Woodard. So we are trained to train in McHenry County. We have offered that free with the exception of the books, so that we can continue to train as many recovery coaches as possible. But that is getting harder and harder to do because it really falls on me and Brenda right now. And so there is a academy, which is 30 hours, and then there's, if you get an additional 30 hours, you can apply to become a recovery coach designee. A designee allows you in the nation to travel in between states and recognize yourself as a recovery coach. In some states, that allows you to become employable and insured billable in different states. Here in Illinois, though, we recognize certified peer support specialists. Certified peer support specialists in Illinois have 110 hours of education time, 300 hours of internship time. CADCs need to have 225 hours of education time and then a work program. So what we want to be able to do is build people into those roles and allow people to have the opportunity to train at different levels, whatever serves them best, but allow lots of unified conversation, unified types of thought process, and a lot of support. So that's kind of what the whole goal of this is. Okay. Why do we want to do it? First of all, we need to increase our pool of peer support. We, for example, you're going to hear from Brenda about the education program and the need for peer support in her program. We know that New Directions uses peer support in their emergency room program. We have talked to the social work program, and it would be nice to do warm handoff to potentially peer support there for long-term intervention in that program. So there's lots of avenues to use peer support, and I think we could explore a lot more to also do it. We want to support that advanced certification to get our people who are in recovery, both for mental health and for substance use, to advance them and be able to offer them opportunities eventually in employment, and also just to feel better about themselves and what they can do. It could reduce our staff cost. If we have volunteers who are trained and confident in what they're doing, we can start to potentially have them being able to do more of what our staff is doing that really they shouldn't be. For example, if we're covering tables as our full staffs that we're paying our full salaries to all weekend, we're either paying overtime or we're asking for more staff because we can't man what we need to do during the weekday. So we hire more staff, or we submit to the mental health board or to the community foundation or other grants for more and more staff, when really, if we have a good solid volunteer base that has confidence in what they're doing, they could possibly manage those positions. The same with recovery coaches. If our social workers could pass off to recovery coaches who are skilled, or our certified peer support, we could potentially pay people, those positions are paid less than, say, a full-time social worker. So we could reduce our staff costs or our staff positioning in that way. We also can increase our network resourcing, because peer support can rely on each other and build specialty areas. So for example, Brenda has youth-based recovery coaches, New Directions has emergency room-based, other people might have things that are more specific to, say, anorexia, NAMI is more mental health. But then we can all rely on each other to resource better. Yeah, it's not advancing. So this first grant that I submitted for is actually year one. So it is a lot of infrastructure that I put in. So it doesn't allow for me to hire, outside of offering for some time for trainers and a data person to help create a website. It is a lot of me doing a lot of work in the community, and I understand that. But then year two, it builds, and it allows for more trainers, more staff, more people to be engaged in it. I'm going to provide this so that you guys can look at it in more detail, because it is, an idea is to build. And so next year is a lot of infrastructure, support training, with an ultimate goal too, for the financial part of it, to reduce from grant funded into self-supportive. These classes, these trainings can be then, once we have it established here, we can promote it to outside. I do have interest already from Lake County to bring their staff here to be trained, and that is something that we could then charge for outside agencies and let mental health and recovery coaching and peer support here in McHenry County be funded at no cost. So here's some additional things. The advisory committee is key, because one of the primary things we want to do is get peer support training here in McHenry County at our university, either at Aurora University or at MCC. And the state grant that mostly funds that project requires an advisory committee. But I also think it's critical that if we have multiple agencies with peer support in their system, that we would have a committee that would guide the education, guide the goals, guide the focus, do that kind of thing. So I think it would be important to develop an advisory committee either way. Community development and employment development kind of go hand in hand, because it would be developing, making people aware of what's happening, how we can use recovery coaches, finding ways to use it, and developing that component with the workforce network. One of the areas that I've already talked to who's very interested is fire service. They have looked for a long time, looked for ways to follow up with some of the people they have constant contact with. And because of our HIPAA guidelines, they can't really let us know always, but if they had a recovery coach in their system, they would be able to potentially have follow-up and decrease the risk that's associated with crisis. Oops. And I believe I stayed within 5 to 10 minutes.
You did. Any questions that anybody has for Lori?
I answered everything.
Oh, you answered everything, I guess. Thank you so much.
All right.
If there is, I'm sure we'll get back to you. Okay, the next one is Crystal Lake Teen Center Break Prevention Education Program. No. Press the green button, Brenda.
Now it's green, okay. Ooh, now you get to hear me.
Okay.
I thank you for allowing us to present this next level to the break that we are beyond excited to be presenting. Most of you know the history of the break and how it got started. It got started with myself, my son, and his friends, and it is the result of what the kids in our community want to see as a safe space for them to be able to hang out and have opportunities. We are now going on 12 years, and in those 12 years, this last year has been growth, beyond growth, which is super exciting to me. We're going to talk about our prevention services. We've been prevention since we started, but we've expanded on everything that we do and made it a little bit more official. We partner with Turning Point. We have a staff member who works for Turning Point 35 hours a week and then comes in with us for 5 hours a week. Why that is extremely exciting to us is we have a staff member who's building connection and trust with our members, because that is the key to everything that we do beyond bringing in educational programs. We now have a dog that's being trained to be a therapy dog. We have this out-of-school suspension program that I'm very excited to tell you about. So the suspension program, again, remember, this is all a result of my lived experience. I had a son who got suspended pretty much his first week of high school. And I remember being, okay, how am I going to do this, right? I've got to make sure he gets his schoolwork done. I got to make sure he stays out of trouble. And I'm not going to do anything that I plan to do because I got to make sure that he's doing these things. And it was really, really hard. When we started the break, it was always an idea. If kids get suspended, this would be a great place to come and to be supervised so that you could do your schoolwork and you could have support. That was 12 years ago. The opportunity came up for us. We had District 47 has partnered with us since, but not just this school year, but the last school year. And we were going into the school. If kids got into trouble, our staff would go in and do vaping presentations, either in the school. If they got into trouble, they would have to set it up with us, come into the break with their parents, and learn about vaping. We have a great presentation. And I had told Kristen Schmidt, who was working with me, I said, you know what, just remember, if they get suspended, we would be a great place for them to come. Well, lo and behold, by February, and I'm going to be honest, I was on vacation, and I had Best Communities, I had Lori Crane working for me, but Kristen contacted me when I was on vacation, and they were over their skis with kids getting violations for vaping. And she said, can you do something for me? We don't want to expel these kids. We need to do something different. So I called Lori and I said, look, I really, really want to do this, but it's hard for me to do this where I am and convince my staff it's a really good idea while they're already stretched to the limits. So Lori and I and our staff pivoted, and she convinced them this was a good idea. I'm skipping all over the place. Hopefully you read my side here, because I don't want to go past my 10 minutes. We already talked about what we are. So we pivoted, and I'm going to let Lori take the rein on this, because what we were able to do, and it really piggybacks on what she talked about with the recovery coaches. I am passionate, beyond passionate, that we need more coaches, and we need more community members to be trained, if possible, but to understand what this is and how to connect with people. We can't always get them into treatment. Even if we can get them into treatment, they may not want to go. And if you have a coach, and you have that connection that you can build on. I have a person that for 7 years I've walked the journey with her through a lot of different things. That is powerful, and it does lead to change. So I'm going to turn this over to Lori for a minute so she can talk about exactly what our suspension program is and how this all relates to what she talked about and a little bit of what I talked about.
So the main problems that we saw coming into so we started the program in March of last year, thinking we would have 3 or 4 kids, maybe up to 8, maybe by the end of the school year. I think we ended up with over 45. We started in March, we had 1 week off. We never really had a break from that. So what we saw were repeated use of substances, kids who were distributing the substances, so we got to learn a lot about what was happening in the middle schools as far as distribution. And then alternate substance-related offenses were things like purchasing, selling, or on social media posting about parties on a regular basis. So those were the kids we saw. So again, these slides will be available to you so you can read all the details. But in general, the out-of-school suspension provides an alternative to home suspension, provides evidence-based prevention education while also supporting their academic needs. We do that with a recovery coach, an academic, so somebody who's a substitute teacher. The recovery coach also provides a one-to-one time, and then we also provide feedback to the school administrators at the end of the time. And we also have the advantage of, because it's a voluntary program, we can require that the parents have to attend an education session, which is something a school cannot do. They can't force a parent to do anything, so we can. We're not, yeah. So it's easiest to talk about our program by talking about looking at a daily agenda. So we try and have half the time frame as a classroom time. So that is something the school demanded. That one-to-one intervention is used. It's a 5-day program is our preference. We did offer some 3-day programs, but 5 is really our preference. So the one-to-one intervention is kind of that, why are you really here? Not just that you got a vaping violation or an alcohol violation, but what is the real story behind all of it? So it takes that 5 days to build our trust. And then they have some sort of physical activity. We really found, at first we weren't really incorporating that, but we need to get them out of the building or getting them to do something on bad days. Our prevention education includes vaping, cannabis, alcohol if that was part of the violation, brain science, and then we also bring in Live for Lolly, and they do an naloxone education, because we found almost all these kids, if it wasn't in their friend group, it was definitely in their family group, that we needed to have that. Outcomes from spring, so we got raving reviews from the parents and the kids. They truly loved it. They had a lot of good feedback. One of the key things we learned with the students was that we did have kids who actually stopped vaping while they were with us. Not only was it by self-report, but we saw it in their withdrawal signs. So we saw them with the tremors from nicotine withdrawal. We also saw it in their sleep patterns. They were talking to us about their sleep patterns. So not only was it actual self-report, but we could actually see it in what they were physically showing us. We had a lot of conversation with them about that. And then to give you an idea how that goes back to the school is, in our report, we would ask for the nurse to monitor them when they came back and say, we know that they're in withdrawal. We would like to have the nurse see them at least once a week to help them monitor withdrawal symptoms. Their Google classwork, teachers loved us because not only was their Google classwork done, but it was done correctly, not just filled in. So we would actually go through it and make sure it was done. Most of the time, their classwork was not sufficient to fill the time frame, so we went back and looked at their 0 grades and had them redo those, or low-scoring work. So teachers were surprised that when the kids came back, they were actually caught up and were caught up in a way that they could participate in class, which they weren't doing before. So that was a big piece of feedback we got back. We navigated to educational services, recreational services, and therapeutic services in the community. So especially because we were at the end of the year, we looked at a lot of how are you going to fill your summertime. We added at the break a summer program because so many of the kids had no place to go over the summer, and so supervision was an issue, so we added a whole program. And we provided basic needs. We found that the families in a lot of these cases did not have enough food, so food was a basic need that we found we were supplying a lot of. Interest in this model grows. Right now, we're looking at, we just had a meeting with Harvard yesterday. They're interested in developing that program in their community. So in order to do that, we would need to find a partner in their community, talk to them about all the things that a school needs to do with administrative commitment, transportation, developing that whole component. And then the other area that's interested is McHenry. So as we look at what we're asking for with you, that would be the expansion that we're talking about. You want to talk about that?
As Lori mentioned, anytime I bring this program up and how it was actually run, any district that's listed up here and beyond, their interest is piqued because it is a very overwhelming problem that they cannot keep up with. So this model is something that we're already sharing because we piloted it. We have a lot that we can, just hand people and train them to be able to do. Because I'm running out of time, I really feel like it's important to piggyback on everything Lori said about our agenda and what we did. The most important thing that we did when the kids came in was earn their trust. And we earned their trust by having conversations with them, letting them know that it was a safe space. We learned very quickly that the kids were afraid to share certain things at school because many times it was shared. So once we were able to earn that trust, we were then able to do a lot of the referrals. And they were successful referrals to either counselors, different therapeutic options, but even things that would help drive their goals, right? They're there because they got into trouble. It's like, how does this look if you want to play basketball this year? I had another one, wanted to play football. Having those conversations on how that looks and looking at their goals and bringing in Phil Wallace, who has a basketball program, bringing in consumer credit counseling because they're entrepreneurs, need I say more? Different things like that. That was powerful because they knew that we were interested in them. And the kids that Lori talks about, they still come back. Whether they're there every day on drop-in or not, they're still coming back. We heard from them all summer long. Because I am running out of time, 45 seconds to say thank you to this mental health board. We received, thanks to the generosity of this board and a consultant, I was able to work with the consultant to get the base prevention grant that's also going to work with us to expand this. It's very powerful. We could not have done that without your support. District 47, the bravery to be innovative right now was off the charts, and then the Community Foundation for McHenry County for our Youth Empower Alliance, because we aren't going to do anything for these kids without the kids, and that's our passion. 9 seconds, I'm good. Go ahead, ask me some questions if you have them.
I have a couple questions myself.
Yes.
The children that are referred to you, they give them transportation, the
Yes,
school
ma'am.
district? And
Yep.
how long are they in your program before they go back to the school system?
Oh, so it's a 5-day program.
Oh, 5
So
days.
the daily hours would be 10:30 to 2:30 with the option to stay throughout our entire drop-in program, which we encourage. So the bus comes at 4:30.
Okay.
The bus drops off at 10:30 in the morning, and then the program ends at 2:30, but they are allowed to stay till 4:15 as regular members. And then they have a membership for 3 months, which we didn't add into there. That includes so that they can have extended connection with us.
Okay.
Membership forever if they want it. But,
Okay.
yes, sorry.
Are there any other questions anybody else has? Okay, Carolyn.
Thank you. I just have a couple. So is it this program that we're talking about specifically for District 47? And
So-
that you're looking to expand, you said, but.
Correct. So we piloted it with District 47 last year, and again, because of the success, because of the interest, we're working to expand throughout the county. Obviously, we love to have everybody at the break. Our space isn't big enough to accommodate, especially since we want smaller groups of kids. Right now, we're targeting middle school kids, but there's interest at the high school, so that freshman and sophomore, they would need separate spaces in order to do that. So we would be partnering with different agencies, if it's Crystal Lake in Crystal Lake, but throughout the county, there are options, YFC in McHenry, Workcore in Woodstock. Harvard is very interested. So that would be our job, is to work on making it work for their community as well as what we've done here, because it'll be unique everywhere.
Okay, and I asked, because it looked like 47 is the only school district that contributed like 25,000, is that right?
They did, that's what we projected for this year.
Okay.
If we didn't get other funding, but they still have a grant that, I think it's a 3-year grant that they have, social emotional grant that they're working on, that they were supportive. We did not receive that last year. We got 8,000, I believe it was,
Okay.
between the time it started and ended. But the projection, given the kids that we had, was in that range.
And then you said there's 45 kids that were, is that specific just to the suspension program that you had done?
No, that would be specific to anybody that we had through the referrals from the beginning of the year, through the suspension program. Obviously, suspension buoyed that up.
Because then at the top it said projected served 800. Is that with the education program, or is
I
that
believe
overall?
that number there would be because when we go into the school classrooms,
Right.
that would be different than when we're getting referrals because they've been suspended.
And the program, the prevention education program, is all inclusive of both of those?
Yes, yes.
Okay, that's all I have, thank you.
Okay.
Anybody else have any questions? Okay, Lindsay.
You had mentioned the linkage between volunteers, recovery coaches, et cetera. Are you, in a future vision, are you seeing this need for a pool of people that would be able to come in and, let's say, if Harvard had your support to set something up, that they needed the resources of people you see, if we had a trained group of recovery coaches, certified peer recovery specialists, that would also be used in a
That would be a
program like this?
resounding yes. The more that we have to pull from, we have a small pool that we pulled from, and Live for Lolly came in, obviously, because of the awesome education they do, but Charlie Sullivan is also a recovery coach. I'm a recovery coach. Ashley Burke is, Lori is. But our pool is pretty small compared to what it needs to be in the county, especially if we're going to expand this way.
And if it wasn't staffed in that way, what the alternative option is that you would have to have like a teacher level person?
So the way that our grant has been written for this year, especially through BASE, is that, so for the break, we're hiring a position right now that would manage the program. So we have oversight, that person would manage the program. We have a pool of teachers, we have a pool of recovery coaches, but that person would also be able to contribute to that as well. But if you're talking capacity, yes, we need more. And at the break, we will be training as many people as we can. We train our staff as often as possible.
Thank you.
Anybody else have any questions? If not, thank you so much.
Thank you, seriously.
Mathers Recovery?
Hi, I'm Dr. Vamori. I'm the medical director at Mathers Recovery. Thank you so much for having us here to talk about our OTP dispensing program that's going to expand our coverage into McHenry County. And I apparently don't know how to use this device. That wasn't in med school. So right now, our goal is to empower individuals affected by addiction and mental health challenges through comprehensive, holistic, and evidence-based care. Currently, we have OTPs in Fox Lake and Elgin, and we're looking to expand into the McHenry County area to serve the population here. Currently, about 30% of the clients in our 2 locations are actually from McHenry County. Looking back to the mental health board's needs assessment from 2022, about 8% of adults report substance abuse disorders, and 40% of the residents live greater than 30 minutes away from the nearest treatment facility. Only 35% were able to access appropriate care, and 50% have co-occurring mental health issues. And this is particular, yeah, slower, closer? Yeah, a little closer. Is that good? Yeah. Thank you. And with the mental health issues, one of the things that we've tried this year is really to incorporate having psychiatric nurse practitioners in all of our OTP locations. So in addition to just treating addiction, we're also treating co-occurring mental health issues. And also, in addition to methadone, we also provide buprenorphine, Suboxone, Vivitrol, and Sublocade. So, let me go back. So prior to COVID, methadone's been around to treat opiate use disorder since the early 70s, but it was very labor-intensive on part of the patient because it's a Class 2 controlled substance. They had to come every single day for dosing for 90 days. After 90 days, if they were compliant in the program, they would get 1 extra day of take-homes a month, and it would take up to a year before they were able to just come once a week. And that's assuming that they stayed in treatment and were compliant. So the rate of dropout was incredibly high. And then COVID happened. And during this time, SAMHSA was forced to increase allowable take-homes, and we found that nothing horrible happened. Risk of death did not increase, and more patients actually stayed in treatment. And so as a result of those changes during COVID and what we learned during COVID, SAMHSA has permanently allowed more flexibility in take-home dosing. And that's kind of why we're able to provide this program now, is because we can transport methadone to Crystal Lake 3 times a week to allow patients to come there and dose in the Crystal Lake office. So this is a kind of a branch of the OTP, and what will happen is the patient will initially come to one of our locations in Fox Lake or Elgin, do the initial intake assessment there, and then once they're an established client, they can present to Crystal Lake. Their doses will be prepared in one of our other OTPs and only transported to the Crystal Lake location. And that's really important from a SAMHSA perspective because we are not dispensing on site, because dispensing on site would require a higher level of security and things of that nature. So this is doses that are dispensed at Elgin, specific to the patient with the date, the dose, the patient's name, and then brought to Crystal Lake, and we can do observed dosing there, and then they will get 1 extra take-home until we come back to Crystal Lake a day or 2 later. There's also going to be a full-time CADC counselor there, and we will be providing blood and urine as well. So sustainability, 30%, like I said already, 30% of the clients are from the McHenry County area. If we have enough patients that are involved in the program, one of the options we have long-term is what's called a methadone medication unit. So it's a smaller OTP. So SAMHSA allows us to work with our current OTP license and establish like a mini OTP in Crystal Lake, which would be much easier than opening up a full OTP there. So if this pilot program works, I think that would be kind of the next step in terms of having more opportunities for patients in the McHenry County area. But obviously the methadone medication unit has more security involved and things of that nature, which is why we didn't want to do that at this phase, but really look at that as phase 2. So our program goals, again, to remove barriers of care, particularly from a distance standpoint for the McHenry County patients, improve healthcare outcomes, quality of life, treatment of co-occurring disorders, increase accessibility to evidence-based treatments, including methadone, Suboxone, Sublocade, Vivitrol, and address growing community needs. This year, we've already brought on a peer support counselor, as was discussed earlier, who has been really wonderful to have in the clinic, and the patients have really connected with him. He's doing a lot of community outreach in terms of preventing overdose education and things of that nature. And I think that's all I have. Questions?
Does anybody have any questions? Okay, Adam?
Hi there, thank you for your presentation. I know you kind of clarified that it's not going to be a methadone clinic per se in Crystal Lake. What does it look like for you transporting medication across
Yes.
that area?
So it's going to be in a locked box. It has to be either a nurse or an MD that actually transports it. And then in the Crystal Lake location, there will be a safe to secure it. There will be no medication stored there overnight. If anything is not used, it'll be destroyed that day in the clinic.
And is there any licensure issues that you have between Kane County and McHenry County?
I've actually talked to the head of SOTO for Illinois, and he didn't think there were any issues with the program in terms of transporting.
Okay, that would be something I'd be concerned
Yes.
about, because I know, like, when you talk about, the company escapes my name now, McKesson, there's issues with them.
Yes.
And where they're allowed to go and how they can transport, and because now we're transporting controlled substances.
Yes.
It changes that whole dynamic. And then, is it a doctor that's dispensing that there in Crystal Lake, or?
It'll be a nurse, an OTP qualified nurse who will be
Yeah.
dispensing.
Okay.
Yeah,
Under the supervision of a doctor?
of course, of course.
Okay.
Yeah,
Thank you.
yeah.
Anybody else have any questions? Carolyn?
So the 50 of the projected serve, is that in McHenry County? Is that
Those are new unique clients, not.
specific to McHenry County?
Correct, correct.
How many total overall, do you know? Because it looks like you're.
So we
kind of
have
developed.
300 total, so 30% of 300, which is 100, right? Is that math right?
Close.
Okay, thank you.
Any other questions? If not, thank you so much for
Thank you.
presenting. Okay. Our next program to present is New Directions, Addiction Recovery, Housing for Sustained Recovery. And of course, we'll be timing you, Bobby.
Cool. Okay. I'm Bobby Gattone, the Executive Director from New Directions. I tried like 6 times to get the highlight off of that, so sorry for the yellow. I tried to get the yellow out of there. So we're presenting today on a new program, which is funding for an apartment building for 3-quarter living in Woodstock. So what is 3-quarter living? 3-quarter living is transitional housing for individuals with 1 year or more of maintained recovery. Essentially, it's successful graduates of our sober living program. And there's traditionally always been a bottleneck. Currently, we have 5 beds of 3-quarter living available with 58 beds of sober living. So as you can imagine, we don't have nearly enough beds of 3-quarter living for the people who leave our sober living and need it. I can tell you, I'll address that in the next slide. It supports independent living while providing access to resources and case management. So essentially, these apartments are really independent living. This program in particular, we're capped at charging 80% or less of fair market value rent. So essentially, these are independent apartments. The only difference between this and another apartment would be the affordability, the fact that they would be drug tested monthly, and have to maintain sobriety to stay there in the interest of the other residents, and they have to meet with a case manager monthly. So it's a big step down in care from sober living, where they're meeting with case managers weekly or biweekly. And there's a lot more independence. Obviously, they can come and go as they please. And this project in particular was really ideal for us, the location, because it's only a half mile up the street from the retreat in Woodstock, where we have all of our housing staff housed, and over 30 beds of sober living there. So it'd be just a half mile up the road. It would be 6 2-bedroom apartments, creating 12 new beds of 3-quarter living. So the need, anecdotally, I can tell you the number one need, the number one cause of relapse of successful residents of sober living once they leave. So most people that relapse and have to come back within 3 months of moving out, it's because they could not find a safe and affordable place to stay after they left their sober living. As you can see, there's some statistics here on the need. Only 36 out of 100 low-income households have the rental units that they need. Recovery housing benefits individuals by improving mental health, reducing strain on emergency services, and creating safer communities. The goals for this project are to provide affordable and supportive housing for individuals in long-term recovery, and to help people successfully transition back into society. So right now, the background on this project, so this project started with a grant that we applied for from ARPA funding almost 3 years ago now, just over 2 years ago. And we were awarded $980,000 for this project. When you go back to when I actually completed the application now, it was almost 3 years ago, and things were a little more affordable than they are now. So the cost to build this has gone up since it was already a pretty conservative budget to begin with. So essentially, it took us about a year to find the location and secure that and purchase the property. We're going through architecture and engineering, site prep, and that's where we are right now, is working on zoning applications. We finally have all the subcontractors secured. The bidding process took us a long time as well. We're targeting a realistic date to actually have people living in this building would be November or December of 2025, so just over a year away. Essentially, we've phased this program out to make it possible. So we're using the initial ARPA funding for underground work, plumbing, electrical, concrete, and insulation. Phase 2, which is the funding that the Mental Health Board will be helping us with, would include the cost of framing, carpentry, framing materials, and HVAC work. Phase 3 would include some of the smaller finishing touch type items where we could, we're going to have people volunteer to help us paint. We have discount rates for things like roofing and siding from some preferred contractors and board members. So phase 3 is the items that we're able to pull out and do really affordably at the end of the project. So what's real crucial, I should mention about this request is the program is very possible. This project is very possible and we're very close, but obviously I didn't want to take the step of breaking ground until we knew we had funding secured to really make the whole thing happen. So, this request would fill that gap in funding that we need to complete it. Success will be measured by regular case management, very similar outcomes to what you see in our sober living program. Just on a, like I said, a less frequent measurement of once a month. We get resident feedback and 6-month follow-up through a GIPRA tool that we started using through our federal SAMHSA grant, which is really in-depth for outcomes. And we do annual reviews of the tools and evaluate processes at management level to make improvements. Some evidence-based practices in this program are going to be, again, real similar to what we have always done in our sober living program. 12-step facilitation therapy, it's all going to be 12-step based, just like our sober living program, and abstinence-based. We have trained staff in our case management to support. We're also hoping, with the location being so close to the retreat, we're hoping to roll in an element of mentorship, because we really try to pull back, the people who are successful and end up staying in sober living through to 3-quarter living. We try to pull them back into the house meetings to support the new residents in sober living. A lot of times, the peer support is more impactful when somebody's not only been through that program, but been through the program recently. A lot of times when you're new in sobriety, you're more likely to listen to someone with a year sober than someone with 20 years sober, because it's just more relatable. So we're really hoping to add that element in as well. So as I mentioned, I kind of jumped ahead and talked about some of this as far as how we're funding the project. What I didn't mention, there's also about $100,000 that we're going to be asking for through CDBG in the current round, which should be available right around when we tackle that third phase of the project. We also have a few major donors that we've already had conversations with that are willing to help with $50,000 to $100,000 at the end to get us over the top. Again, once they see participation from the Mental Health Board and ARPA funds kind of working together there. The program obviously has a lot of alignment with Mental Health Board priorities, addressing things like service capacity, gaps in the continuity of care, and prioritizing funding things with best practices. So the thing I would focus on here is the gaps in continuity of care, and I feel like that's something we've always tried to do with New Directions, is meeting the service gaps that exist right now. So somebody going from the moment that they want to go to a meeting or go into detox or treatment until they are, in long-term sobriety. There have been gaps. There's always gaps in our services in the community. Right now, the biggest identified need that we have is this three-quarter living. We've had a huge uptick in sober living beds, but I think where we're losing people now is people tend to leave sober living sooner than they maybe should, go back and don't have the support or can't afford a supportive situation after that. So the impact would be, over the next 15 years, this project would serve 240 individuals with three-quarter living, empowering them to thrive in recovery. And I use the word empowering because it truly is empowering when you see the quality of facilities that we provide. These will be new construction, beautiful apartments, rather than, if you're starting from zero, maybe 6 months sober through sober living, and whatever you can afford at that point may not be in an apartment complex that is as safe or empowering, right? So, and I also think it's empowering to know that you're living in a building with 12 other people. They're all also doing well in sobriety. I'm running out of time. We've kind of touched on a lot of these points already. The community crisis is one in basically affordable housing and the SUD crisis, which is what prompted us to originally take on this project. And you'd be partnering with New Directions, as you have in the past, to help meet some goals of the mental health board in the community. That's all I got.
Right on time. Okay, Lindsay?
I have two questions for you, Bobby. There was a slide on there that showed your request at 261,800. Our notes have 361,800. Can you clarify?
And yeah, that's a great question. So I wasn't sure which numbers to include in the presentation, because since the initial application, I'd sent and since the initial funding recommendation meeting last month, we made a request to the mental health board to move 100,000 that was recommended for this program to the housing program, because the housing program was going to be underfunded as recommended. And we were also able to get the two biggest subcontractors, which are plumbing and electric, in the last 3 months. We've gotten that bid down. So we've saved probably around $140,000 in the project budget since I initially submitted. So it just kind of makes sense. And again, that's up to the board, but that's the request we would have.
And that's because of the loss of the other grant that you sent the letter in about?
Correct. So the reason our housing program is so high priority and it needs that full funding is because of the two grants that fell through this year were both related to that program. Yeah.
Gotcha. I have another follow-up question for you. So sometimes capital projects are something we consider with funds and like a mid-year. If we weren't able to fund phase 2 now, but if there were dollars later, is there a deadline that you have to raise enough money without losing other dollars that have been provided to you to move forward?
So the ARPA deadline would be, we have until the end of 2026 to expend that fully, but I guess the bigger urgency is, based on the need and us already kind of having to push the timeline back to this point, we would be okay if this funding wasn't, if we couldn't access this funding until, March or April, because most likely we wouldn't be to the point of framing until then anyway. But the issue would be, we would be hesitant to start the other phases of the project until we knew, you know what I mean? If this was still up in the air, we would hold back to start anything else.
Okay, thank you.
Any other questions that anybody has of Bobby? Okay, Adam?
Hi there. Excuse me. Thank you for your presentation. If we aren't able to get you that money, we talked about, or you spoke about the challenges with people going from sober living to back out in the real world, can you apply a portion of this money to your sober living program to enhance that so we can help those in need a better transition? Is that an option, or is that because we're locked in on this, it's not going to work?
So, to answer your question, I would say, I guess we're already doing everything we can to help with the transition. Some of it is kind of built into the model. So, essentially, people are going to leave the more structured sober living for a variety of reasons, right? And at the point that they leave is when they tend to not have a great setup for the next place, right? So our case managers do a lot of work with them to make sure people are saving money, to make sure they're spending, that they're letting us know 3 months, they're supposed to let us know 3 months in advance when they plan to leave. And then we work with them to find a safe and positive environment for them to move into. But it's not, because we're kind of in between treatment and independent living, we have less control over that. So just by human nature and what people are going to do over 8 years of experience we've had, individuals just aren't ending up in the best situations. A lot of times they take the cheapest apartment they can find. We can help them save, but to save enough for, a lot of times it's $1,800 for first month and $1,800 security deposit, and people just aren't able to save that much with the jobs they have. So that's the other appeal of this, would be that they wouldn't have to save for a security deposit. So I hope that answers your question, but I just want you guys to know we are already doing everything we can to do the best with the situation we have. So I guess this would be what we identified as a priority that would help most. Yeah.
And just one other follow-up question. The original ask was $361,800. You're suggesting that we could basically subtract 140, if I did my math correctly with what you said?
I think the ask would be, so the recommendation came in last month to fund, I think, 110,000 or so, less than what we asked for sober living. So the request was just to move, if you could move 100,000, because the recommendation was also to fully fund this program. So what I asked was if you're able to move 100,000 from this program to the sober living program, which would lower this one by 100,000, which would work because of the fact that we've been able to save over 100,000 in the budget since we first applied.
So you're not asking for a reduction in an ask, you're just asking for it to move from one line item to another?
Correct. Yeah.
Okay.
Any other questions? Carolyn?
Thanks, and I appreciate that, because I asked that 1 or 2 times ago, I think, on when you have multiple programs. So I appreciate you trying to work out a solution and request to us, so we're not the ones guessing as to how you can move money around. So you said each individual lived there 9 to 12 months. Was I reading that information right? And
Yeah,
like
the
12
goal is
people
9
at
to
a
12.
time?
Yeah.
And then over 15 years. So do you have some type of guarantee that your organization owns and houses those individuals in that building for that 15 years?
So we do have, God, and I'd have to review it, to be honest with you, and I can get back to you with the details, but I believe we're beholden to use it for these purposes for either 15 or 20 years,
Okay.
based on the ARPA regulations too already.
Okay,
Yeah.
great, thank you.
Are there any other questions? Chris?
Hi, Bobby, thanks. So funding low-income housing is just mind-boggling to me, so my questions are probably redundant with things you've already considered and examined. But I just wanted to inquire as to whether Illinois Housing Development Authority first mortgages for construction to permanent, permanent housing would be an option. Like if you were to take out a mortgage and we were to help contribute to that on a yearly basis rather than a giant upfront chunk of money, is that a model that might potentially work?
So we've reviewed that with Crystal Lake Bank and Trust, which is who we've used for other banking we've done. I mean, the short answer is It would be possible to get like a partial mortgage for building, but it'd be extremely difficult. So it would draw out the timeline. It's also, the way it was explained to me is it'd be very messy from the lender's perspective because we have partial grant funding. They would want, basically they would want to kind of manage all the different subcontractors. To be honest, the only way we're able to build this building costs have gotten so crazy. If we were to do full prevailing wage for every single trade from beginning to end, it'd probably be over $2 million from what we looked at. So part of phase 3, for example, is we're going to pull that out to use volunteers and some non-union workers. So the prevailing wage requirements will be met for the ARPA funds and for mental health board if you guys funded. But we have to pull in some other trades outside of that we're using our own funds for. Some of that wouldn't be possible with the mortgage element. So it just gets
Yes.
Messy.
more difficult.
Yeah. I don't know if Illinois Housing Development Authority construction to permanent loans are different than what you're looking at, but I just wanted to explore that possibility and just see if there are any other funding models that might fit.
Okay.
I think you
Thank you.
have to use prevailing wage, and so that really limits. Yeah.
Yeah.
Any other questions to Bobby? Well, thank you very much. Appreciate your presentation.
Thank you. Thank you, guys.
Last presentation is Rosecrance, Veterans Peer Support. And if you just move thank you, then we can hear you.
Shorter.
Yeah.
Hello, I am Dominique Nagel. I am with Rosecrance. Thank you all for inviting us here today to talk about the Veteran Certified Recovery Support Specialist. Yeah. Yes.
Oh, yeah, that's a lot better. Okay.
Okay, so with the veteran CRSS position, they would be partnering to develop collaborative multi-agency approaches within McHenry County to facilitate coordination of care. They would be reaching out through outreach and engagement efforts in the community, attending community events and task forces, attending crisis calls in the community for veterans, engaging in peer support, resource navigation and linkage for veterans in the community, and then also assisting with that care coordination and collaboration for these veterans. The intended outcome of this program is just to help more veterans in our community gain access to care and reach recovery through outreach, engagement, and community collaboration. So this peer support specialist will connect directly with at-risk military members and veterans to increase social connectedness in the community, increase access to resources, access to VA healthcare services, and just working to develop that system improvement for VA services in our county. Okay, Cardinal.
Yeah, so that's what I do. My name's Dave. I'm a retired Army colonel, 30 years. I'm here with Dan Baggio. Colonel Baggio and I worked together at 3rd U.S. Corps 24 years ago, known each other ever since. I am the peer support specialist for Rosecrance in Rockford. I primarily work in Winnebago County. I cheat a little bit and I go do things I'm really not supposed to do, but I do it to help veterans out, and we take care of them. We absolutely do. So, the idea is that you collaborate with different parts of the community in helping out every veteran that comes into our outfit, Rosecrance. I meet him on the street. I'm the guy that hugs the bed bug guys, okay? I meet him underneath the bridge. I go down to Jubilee, I meet him. I meet him down at the Veterans Drop-In Center. I'm actually on the board of the Veterans Drop-In Center. I meet them where they are. I talk to them. I slap them on the back and I say, dude, come on. You were in the Army, you were in the Navy. You know, we talk. I ask them what branch they were in. They tell me what their MOS was, what their job specialty was. I can relate to that. If the guy was a field artilleryman, I know he went to Fort Sill. I know he spent time in Graf. We talk about those things. We make that connection and it works. Okay? Dan works up at corporate. He does a lot of business development stuff. Anybody ever heard of a Army of One? Remember that Army of One thing? Well, Dan and I are an Army of Two, okay? And so what we do is we coordinate all the different aspects of Rosecrance to bring all these services to our veterans. So you're looking at 2 retired 30-year full colonels. We both have a couple master's degrees. We are both going through the CRSS program at NIU. And in that program, you get everybody from the GED person to a couple master's degrees people, okay? And so we're getting the certification because we both switch back and forth. And we both work the street or work the suites because there's only 2 of us, okay? And we talk to veterans. So go to the next slide. This is my pizza slide, okay? All right, so the pizza slide is basically this. So got there, there were a bunch of services that were available in Winnebago County. The problem was connecting the dots. In every community, there's some place that's a watering hole, right? That all the creatures in the woods come out and they go to the watering hole because there's something that there they can get. In Rockford, it was the Veterans Drop-In Center. All these different agencies came into the Veterans Drop-In Center all week long. I was trying to build a program. I said, hey, how can we, this is where everybody comes, man. How do we do this? So it's easy. Why don't just everybody show up on Wednesday? And we started having lunch. So we started doing that. So we formed what was called the Veterans Leadership Team, okay? Illinois Department of Veterans Affairs, Illinois Department of Employment Services, the Veterans Assistance Commission, and others would all show up. And then we'd have to be careful about HIPAA stuff, but we could share information on clients. So the person, for example, that's with Illinois Department of Employment Services, right? They would come and sit down and we'd be having lunch. Hey, Dave, I met this person. I'm helping this person get a job, but I really think you need to talk to them. That's my cue. There may be a problem with substance use disorder or mental health. I'd be out on the street all day long doing my thing. I might run into somebody that is okay that way, but they just need a JOB, right? And I'd give that name to the other. So we form this thing. So go to the next slide, if you could, please. Oh, thank you. I'm glad you're running that thing. All right. Does it work? There we go. So, food, water, housing, shelter, laundry, communication, cell phone, transportation, bus pass, a JOB, detox, rehab, whatever they need. That was our core group. Then people found out what was going on. The Jamie Cox Foundation, okay? Ingersoll, oh my God, all of them. Marshmallows of Hope. I just talked to Bob today from Veterans Path to Hope. Financial services, jails, probations, even the Hard Rock Cafe. Oh my God, Dre, you work for Rosecrance and you're asking the Hard Rock Cafe? No, they came to us. We're hiring 40 veterans in the next 2 months. We want veterans. We know you deal with veterans. We're here to help your veterans, and we need jobs for veterans. So it all works. It all works. So a veteran in trouble wants to talk to a veteran if they can. It makes a difference. You have a connection, okay? So let me give you 2 good news stories. I will tell you the names, HIPAA. The first guy is Marie. Name starts with an S, okay? So I'm at Rosecrance. I met Harrison. That's our in-resident outfit. And they call me, hey, there's a guy up on Seaward that needs to talk to. He's a Marine. Cool. So I go up there. He comes out of group, sits down. I said, what's up, man? What's the deal? You a Marine? Yeah, I'm a Marine. Hey, I'm an Army guy. We're talking. And he says, well, okay, this is what happened. I'm a Marine. He looks like a Marine. He talks like a Marine. He's built like a Marine. He's got Marine Corps tattoos. I mean, this guy is a walking, talking, doggone Marine, I'm telling you. Okay, so he sits down in front of me. I'm a Marine. Yeah, I can see that. What happened? Well, about 20 years ago, I did something stupid and I got a bad conduct discharge. And my grandpa's a Marine, my dad's a Marine, my brother's a Marine. They're all Marines, came from the Marine Corps family. I came home and my mom wouldn't put my picture on the mantle with a my family members. He's got a tear in his eye. He said, so I just left. He had a family, he had a kid, he left his other family, he just left. He went in the carnival for 20 years drinking and drunken. Drinking and drugging for 20 years. He ends up at Rosecrance. And then he looks at me and he says, sir, I used to be a Marine. I said, I'll just say it, what in the hell are you talking about? Dude, you're still a Marine. What's a Marine always? You are still a Marine. You are a Marine. I stand him up, I give him a hug, you're a freaking Marine, dude. Come on. You just got a different level of discharge than somebody else has got. You just get less benefits from the VA than someone else has got. Once a Marine, always a Marine, you're a doggone Marine, and don't you ever forget it. He looks at me, he's got tears in his eyes, he's bawling. Big, strong guy. He said, you know what? No one ever told me that before. He went back into the unit. Oh, before he goes back, he stands up, I'm not making this up, stands up and salutes me, and he says, sir, this Marine's back in service. Goes back into the unit, takes all the leadership positions, Mr. Honor graduate, and now he's down in Central Illinois doing what? Going through the CRSS program, and he wants to come back to Rosecrance to work.
Good for him.
Ugh. That is the connection. That's the connection. Another guy, Ranger. Okay, so my buddy Dan here, okay, he's a Ranger, all right? I'm not a Ranger, okay, but these guys are Rangers. I jumped out of airplanes. These guys ate snakes, okay? So he's a Ranger and this other guy's a Ranger. So Ranger Chris. Ranger Chris walks in, messed up, emotional, physical scars, knee actually swollen up from a bad parachute jump that he never got fixed. Okay, we got him to the hospital, got that fixed. Goes through the detox and rehab program. Well, anyway, I gotta speed it up. He didn't have a place to live when he left. This Ranger over here made one phone call. Because of our connections, because of that will I told you about, we had that guy $2,000 in less than 30 minutes, and he didn't have anywhere to go. I had the donor on the phone. I said, I haven't told him yet. Gave him the phone. Big strapping. This guy was in the Ranger bat. He did 3 tours in Iraq, kicking doors with the SEALs. He's the real deal, okay? He sits down in a chair, puts his head between his hands, and he just starts bawling. So I can't believe it. I can't believe we got a place to live, okay? One phone call from that Ranger right back there. So we have a group of people in Rockford that we've been able to bring together to do this. And so Rosecrance, 3 states, 50,000 clients, 60 locations, 1,600 clinicians, employees. Nobody ever counted them until I made them. 3,172 veterans and veteran family members, and family members are definitely included. So the program is working. And Dan and I, you know, 2 30-year full colonel dudes that roll up our sleeves and get down there on the ground, whatever we got to do, we're going through CRS's training. And it's working. It's why we get up and suck air every day, okay? It works, it's cool, it's effective, it's powerful, and that's what it's about.
I have a question for you.
Yes, ma'am.
Are you planning to come to McHenry County? Is that your goal with this program? I mean, well, I'm just,
As much as I would love for him to come, this position would work with the leadership. So Dan is actually from McHenry County and has many connections in McHenry County. So this team would work with this position. So we would hire someone who is a veteran, and of course, this leadership team would be the ones interviewing, and this individual would be a part of this bigger
will you be
team.
working with TLS around here too, right?
Absolutely, absolutely. So this person would work with all of the local agencies. This isn't just a Rosecrance employee, they're going out on crisis, they're gonna be in the drop-in centers, they're gonna be, because we in Rosecrance, McHenry, we don't provide veteran-specific services. So this is gonna be someone that's gonna be working with the other veteran agencies out in the community. So it's like a community person.
And I have one other question for you. You were saying that Hard Rock Casino, is that it in Rockford? They're hiring, I mean, if I heard you. Well, they were hiring veterans.
Now they're pretty much stood up. I don't know what, the HR guy from Hard Rock, I got a big mouth, so you can.
Well, I just heard. you
The
say-
HR guy from Hard Rock is a former Marine, got out in Florida, was floundering, really tough time in transition, got hired by Hard Rock, did good. He's the guy that ended up here,
Okay,
and
okay.
he was hiring all these guys, and he found out about us, and so that's it.
They're
Why?
still hiring because we have a big event coming up on the 8th of November. If anybody wants to come, it's called Saluting Veterans. It's a big event we're doing in Rockford, and we're giving out educational ECUs to come to it. But anyway, Representative Vella from the Rockford area is setting up a table because he's linked up with the people from Hard Rock. They're still hiring people. I think they still got 40 positions out, yeah. So, yeah.
Well, I admire you two being a ranger. That's a tough job.
So real quick, okay, so.
Okay, I'm just.
It's- I gotta
Any,
let you.
any other questions?
Yeah, I just, wait a minute, let's see. Carolyn has one. Go ahead.
I just wanted to first thank you both for your service, and I have to say that veterans have the best stories, and always a pleasure to hear from you and what you have to say. As I'm trying to understand this position specifically, have you done research within McHenry County and the current services that are provided here for veterans? Because I'm trying to distinguish between the existing services we have and those that we even fund, and what this role would do in finding the gap that may exist. And have you surveyed that, or how do you know that?
So this role we envision serving as a connection between the services that exist in McHenry County. So one way that we see them working in the community is going on crisis calls. So we do have our mobile crisis response team within Rosecrance. If a veteran is identified as someone who is needing a crisis assessment, this role would attend that crisis call with them to help that connection. There are, I'm sure, many veterans that are not connected to the services that we already have, and we're trying to help bridge the gap for those individuals. So helping them navigate the system, finding the resources, because they may not have gotten connected to anyone, and we want to help those connections to the services that already exist in McHenry County, as well as improve the services that exist. So like Colonel is saying, getting people together from these agencies that are providing these services to, again, identify any additional gaps, to help bridge those gaps and develop new plans for new services and how to reach more veterans in our community.
So then the numbers that you have, the projected number that you would serve at 30, is that based on your Rockford numbers, or?
No, Rockford's over 100 clients that they have served this past year in just Winnebago, so that doesn't include anywhere else. I think for us, I didn't want to project too high, because I don't know. I don't know what that number will be. So that is what.
And then there was a notation then at the bottom that says the program could utilize Medicaid once the position obtains the credentials. So is this do you anticipate this being kind of a startup, or at what point could they use Medicaid funds, or when?
They wouldn't until they're fully certified as a CRSS, before they could even bill. So that is not the goal for right now. It's actually finding a veteran and then getting them up and going and doing what we want. But then being a CRSS, you'll have to do all of that before that they could even be certified to even bill.
Okay, and then this is for one position, the 156,000? And then, so either it comes or doesn't come? That was kind of where you're at? You're not planning on bringing it unless we fund it? Okay, thank you.
Lindsay?
I have a follow-up question about the Medicaid billing. Fast forward to getting that certification handled. Do you see billing replacing the entire purchase of position amount?
No.
How much would you anticipate in the future, say 2 to 3 years out?
It honestly, Lindsay, it would honestly depend on how many people they actually serve. And then it would just be case management, which would be very low. It's not like crisis stabilization or anything like that. So I would say absolutely, it wouldn't be able to cover it whatsoever.
Right. It would just maybe reduce it slightly.
Slightly.
That was my nice way of saying it. Yeah, yeah. Okay, thank you, I appreciate it.
Of course.
Any other questions? Okay, well, thank
Thanks,
you
you
so
guys.
much, and
Thank
thank you
you.
for your service. Okay. Member comments? Anybody have any member comments around the table? Okay. Well, with draft plan, we're not going to talk about that. Well, then go right ahead, Lindsay. Well, I thought I did.
I just wanted to say that the one thing that was really interesting for me tonight is every single program that presented all talked about the need for certified peer recovery support specialists, recovery coaches, and that utilizing that staffing level in agencies and the desire and need for more of that. I know I said it before, but all the research really supports the idea that that's where our kind of behavioral health, mental health, human services shortages are going to be met. I'm very much in favor of anything we could do to support agencies across the board, get more people that meet that criteria. And for those agencies that we support that also do have Medicaid billing capacity, long-term, while slight, there are some billing opportunities there. So it's a long-term game, but I just sort of wanted to throw it out there. There was a pattern and a theme into the conversations today. And it would be really cool if there was something long-term where 10 years from now, we had, 250 more people trained in our county or counties around our counties. So anyways, I love the idea of it, I just wanted to share that as my comment.
Any other member comment? Carolyn?
Can I just, so we're done with these meetings now, right?
Yes, our
so
next meeting
one
is our board meeting Tuesday.
So can we just maybe reiterate a plan or what you might have in mind? Is it similar, like if you're going to propose something to offset it, or is like kind of ground zero the current plan? I just want to prepare for the next meeting. Do you have a suggestion on how to do that?
You're asking me that?
Well, I don't
Or
know.
Leo?
I'm asking,
Well-
it can go out to the board on what, I guess I see, and I kind of heard last time, that if there's any suggestions for change, also suggest offsetting changes, correct?
Right.
Okay.
I think that on Tuesday, we'll have to look at our budget. We'll have to look at what we have and what we can all agree on. For example, we'll look at the 22nd court. We'll look at those programs and say, this is what was recommended, we agree to it or we don't, and we're going to go through each program on Tuesday.
And will we get an update of the current, sorry to cut you off there, but will we get an update of the current budget too? Because I think there was,
There is a problem.
the current, existing, right now, the 2024 budget, because I think we talked about potentially being able to utilize some of those existing funds that may have been, where we're at to date, through December. Are we going to get that budget as well?
We should get, well, go ahead, Leo. You want to hit your thing, because I don't, okay.
Yeah, currently, right now, we have about 60,000 of unallocated dollars for fiscal year, so it's only 60,000 we have left.
Okay.
typically, normally, the process for our funding decisions is that it's much easier than it was a month ago normally, in that we don't go through each agency. And that you would just pull out the programs that you wanted changed. But I sent an email to all the board members, which you will have. And again, we will probably do something differently next Tuesday because of the issue that I addressed in the email that we can discuss regarding the sales tax. So we're probably going to be doing some things differently than recommended. That's, so the draft recommendations will be different.
Does that answer your questions? We don't know. Right. You'll have to look at your email.
So we probably will be going, it'll probably be a longer meeting than normal. It'll probably be similar to the first meeting, because we will probably be going through every single program individually.
Yeah. Any other questions anyone has? Tuesday night will be a long meeting, so be prepared. Any other member comment? If not, then I need a motion to adjourn.
So moved.
Second? I'll second. All those in favor? Aye. We're adjourned. See you Tuesday night at 6.